Kenya is facing a rising health challenge, diabetes. With more than 2 million Kenyans likely living with the condition, many unknowingly, health experts are now calling for a shift from treatment to prevention. This was the key message at the 10th Annual Kenya Diabetes Study Group Conference held in Naivasha. At the conference, attended by health professionals, policymakers, and researchers, new data from the Ministry of Health showed that while around 800,000 Kenyans have been diagnosed with diabetes, the real number may be far higher due to undiagnosed cases.
We're estimating it to be much higher, as high as even 7 to 10%. Now, part of the problem we have is one, screening. The average Kenyan does not actually show up other than when they presented with a problem. We have community health promoters, and we are training them in terms of educating them with regards to non-communicable diseases. So they go out of their way to screen and then appropriately refer to the health facilities.
To address this, the government plans to deploy over 100,000 community health promoters equipped with glucometers to enable local screening and early referrals. Also unveiled, a primary health care fund supporting free diabetes testing in public, private, and faith-based facilities.
We want to reduce the cost of medications by around 50%, and we are working on an access program where the Ministry of Health will take lead in engaging with manufacturers of diabetic products and diabetic medicines, so that then we can make this across the private and the public sector a reduction in the cost. Again, hypertension, we are working on access programs in the cancer management and also in the kidney.
The conference also spotlighted policy changes, including proposed subsidies to cut the cost of diabetes medication by half. As experts call for evidence-based, inclusive reforms, it's clear Kenya's diabetes fight must go beyond the clinic into homes, communities, and policy chambers. Reporting from Naivasha, I am Samuel Thawita.
bringing of order may be a bit painful. It may also be very facilitative, but we want you to support us because you're the one who need to determine the environment that makes provision of care safe for your patients and the practice of medicine fulfilling for you. Because without those two parameters, that's the people who consume our services and the people who give it, that is you, every single policy, every single standard that we make at the Ministry of Health is ineffective. And this is the collaborative approach that we are taking, part of what we discussed. And so today, my work here was to come and give you an assignment because you didn't give me any. You didn't give me any assignment. So I've given you my assignment. But soon you will be hearing from us. We want you to be very proactive. We want you to be very innovative. We want you to be very supportive. The benefits package that we have right now under the Social Health Authority is not cast on stone. It's the responsibility of the Cabinet Secretary to review it from time to time. The Cabinet Secretary relies on evidence. That evidence will be brought by the panel that has been gazetted. That panel must speak to you. And you must speak to the economic issues, the social issues, and the health system's context. And talking about that, and I wanted to finish with another mandate of the ministry in terms of supporting you to provide, to get resources, whether those resources are partner-driven. That's why I was talking to you to bring some good proposals that we then can support, because when it becomes a government agenda, then you know it has a higher scale of being supported. I wanted to speak about the context of our funding. We are not America, we are not China, we are Kenya. And so Kenya has a very strong economy. Kenya has a lot of opportunities, but we must look at things from that perspective. We must look at what exactly can we afford, what exactly can we not afford. And we open it up in this our discussion so that the decisions that we make are decisions that are consensus-based, and remember I've used the word consensus-based, and are also evidence-based, because evidence is context-specific. Evidence is not just about what people do in America. For example, on the vaccination front, the good nation of Netherlands does not give rotavirus vaccine. Here in Kenya we do. You know why they don't give it? Because for the last 15 years, there is no single child that has died of diarrhea in that country. Not that they don't have it, but they have never had anyone die of diarrhea. So what is our context? So something may be happening in America as far as diabetes management and treatment is concerned. But must we also do the same thing here? You give me the answer. With those very many remarks, I want to thank you so much for inviting me today. I promise to support you, to facilitate you, and I ask the same of you. Be blessed. And congratulations for your 10 years.
Thank you very much. And because we are about to go for lunch, I'll ask us just to stay standing, okay? Then we'll go for lunch. Thank you very much for the challenging insights. I will ask for your email so that I can send you our 2023, just a report we had put down. And one of the things is so that you can advise us probably about language, because a lot of these matters have been talked about. We have fought a lot for the tax, especially like on strips. Insulin is not taxed, but strips somehow are, so we are